Okay, perfect. So let me start by, of course, thanking again the organizing committee for inviting me to speak today. I'm very sorry that I cannot be there in person due to the problems in traveling for the pandemic. I really wish I would be there with you. But hopefully in the near future this would be possible. So as you correctly say, the topic of my talk today is about timing in the embryology laboratory, and specifically I will focus on the timing of handling the oocyte. And this part of timing in the lab is super important, as you know, for several reasons, but mostly because at least at the beginning of development, we know that the oocyte has a very important part, and also because it's a question that is very often brought up by embryologists. Should I wait for a few hours before denuding the oocyte? How much time do you have between denudation and fertilization? It is depending on something, and how do you handle this? This is a very common doubt. So that's the main focus of today's talk. So when we discuss about timing of oocyte handling in the lab after the ovum pickup, we need to keep in mind basically two mechanisms and two phenomena that work one against the other, and they need to find a balance between them. So on the one end, we know that the maturation of the oocyte and its development to the point where it can be fertilized effectively is basically a part nuclear. So basically the completion of meiosis up to the second metaphase. And then there is a cytoplasmic maturation. And cytoplasmic maturation is something that we cannot assess without destroying the oocyte, because it's related to the proper accumulation of molecules and to the appropriate distribution of organelles in the oocyte. So this part needs to happen, and it usually happens at the same time as nuclear maturation, but it's not something that we can assess before we use the oocyte. And they need to be absolutely coordinated in order for development to occur appropriately. So the question or the topic of what do you do in the lab comes from relatively old studies, about almost 20 years old now, that found that if you wait between ovum pickup and ICSI or fertilization a few hours, then you probably have a higher oocyte maturation, higher fertilization rate, and better embryo quality. And I would like to draw your attention to the fact that these studies did not really say much about pregnancy or other reproductive outcome, and they all stopped at the embryo quality level. And this is something that maybe I can discuss later on. So on one side, you need to have this and give enough time to the oocyte to complete the process. But on the other side, we also need to remember then if you leave the oocyte too much getting old in vitro or in vivo for that matter, but in our case is in vitro, you have a phenomenon that is called in vitro aging. And in vitro aging is linked to a decay of the oocyte ultrastructure, both in mice and in human. And this is a significant issue because when the oocyte becomes old, one of the effects that it has at the molecular level is that it becomes more prone to be activated. And you might have a counterintuitive effect of aged oocytes that are of lower quality fertilizing better just because they are more prone to spontaneously resuming meiosis and exiting the meiotic block. So this can be a confounding factor when we assess the time in the lab. So in sort of associated with this, it has been shown that in vitro culture of oocyte, contrary to what I just said in other studies, for 1 to 6 hours after ovum pickup does not improve fertilization and embryo quality. So we have these two different forces that pull in different directions. What are the problems with this study? First of all, the N, the size, it is in general pretty small. Many of these original studies, they have 30, 40 patients at most, and sometimes even less, which is also one of the reasons why they don't assess anything past the lab, because then when you go to pregnancy rate, then you end up with very few N to look at. Also, in very many laboratories still now, but especially back then, all the timekeeping and record keeping was done by hand. And working in the embryology laboratory, you know for sure that sometimes you don't write as you go. You just finish what you're doing, and then you remember what time it was when you did one or the other, and then you write it down. And this introduces a bias, a recall bias in what we do. And then in very many of these studies, there are confounding factors or factors that you should adjust for that are not taken into account. And all this came to the conclusion in 2015 that basically the optimal time for handling oocyte up to fertilization is not really clear, and it was not clear until relatively recently. And this is where in my group, and then you will see other groups as well, we have decided to look into this issue. And basically we decided to investigate whether in vitro aging of human oocyte is in fact detrimental, as some of the studies are reporting, for their developmental competence, or in other words, we want to understand how do we handle waiting times in the lab in order to achieve the best possible outcome for our patient. And so we started by designing one study which has been published a couple of years ago, and I would like to present it now. So this is a study that has some interesting features. So we took a consecutive cohort design, so every patient that come into the door that fulfill the inclusion criteria was used, and we ended up with almost 4,000 oocyte donation cycles. So I would like to point out that these are cycles, not oocyte. The oocyte are about in 25 to 30,000 oocyte that we looked at. And because, why did we choose donation cycle? Because they are extremely controlled. The protocol for stimulation is the same for everyone. The trigger is the same for everyone. Also, the starting dose is super standardized. We trigger with generate agonist, of course, and all triggers are done. I mean, all ovum pickup is done strictly 36 hours after trigger. And the trigger criteria are the same for all the cycles. So this is the ideal situation to test time in a sort of a controlled way. On top of that, the laboratories of our group are mostly equipped with an automated operator-independent time recording system that in this case, well, is the RI witness, but apart from the RI witness, for the purpose of the study, the positive aspect of this system is that it automatically collects timings of every step without the operator having to pause and write it down. In fact, without the operator even having to do anything, it's done automatically. And this basically take away the bias that we had in basically all the other studies. And this is what we did. So some of these cycles are with the fresh oocyte and some other are with vitrified oocyte. And so we look at the time from ovum pickup to denudation. In case of vitrified cycle, from denudation to vitrification, and from warming to ICSI. And in case of fresh oocyte, simply from denudation to ICSI. And we also look at the biggest time, the long time, from ovum pickup right to fertilization. And so these are the timings that we were analyzing. And how did we analyze them? So the effect of all these times on laboratory results, they were adjusted for a number of recipient couple and donor characteristic. And then we also look at the relationship with reproductive results up to live birth. And then, in order to be sure that what we were seeing from an adjusted perspective was actually realistic, so to speak, then what we did was to analyze also the linearity of these results by dividing the time in deciles, so in 10 equally long times, and then seeing how pregnancy rate, for instance, would change across time. And the prediction is that if we were to see in the first two analyses an effect either in improvement or diminished effect, we should see it in a gradient a long time, or at least this would be expected. So, and we've done this, of course, for fresh and vitrified oocyte. So if we look at what we found, the effect of time on laboratory outcomes, so fertilization and embryo quality, we found that the time that we are looking at is between a minimum of basically 1 hour and a half. Shorter than that, we have no data, because that's the minimum time that, according to the protocols in the lab, can go from when we get the oocyte to when the oocyte are fertilized, and then a maximum, very few, of 17 hours. And if you wonder what might have happened in a lab to wait 17 hours, this is usually if patient come from abroad and they maybe miss a flight, or we need to convert fertilization with using donor semen, and or there is some other, problem that is independent, of course, from the clinic, and so the oocyte of the donor are left there waiting to be fertilized. But these are very rare. The vast majority of cases are within 8 hours. So we found that we could not find an effect of any of the times, not in vitrification or without vitrification, on both fertilization rate and also on embryo morphological scores, and in this type of patients with donor oocyte. If we look at the effect on reproductive outcome, so to understand this table, you should see that we are talking about 3 different outcomes: biochemical, pregnancy, clinical, and ongoing pregnancy. And within each block, what you have are the average times with standard deviation that we see when we have either no pregnancy with the no, or yes, a pregnancy, and then the p-value in each of the blocks. And you see, just by looking at p-values, that there are basically no effect of any of the time, including the total time, on these three outcomes. And this analysis is not just a direct comparison. This is an adjusted multivariate analysis, and we adjust this analysis, so we control this analysis from the age of the donor to the fact that if the semen use was fresh or frozen, if the quality of the semen, motility and concentration, to the day of embryo transfer, if it's 3 or 5, and the number of transferred embryos. Why? Because all these variables are known to have an effect on reproductive outcome, and so we need to make sure that what we see here, either significant or not, is not because of all these factors, but is only because of time. And the time alone does not have effect in this particular population. And if we look at this in decile, so looking at the pregnancy rate in the first 10th of time, second 10th of time, etc., up to the longest time, you see that the pregnancy rate are very stable, are around 30 to 35% across. So there's no trend to increase or decrease. And in fact, the p-value there is not significant. And if we do this same exercise on vitrified oocyte, so we also consider time from denudation to vitrification and warming to ICSI, still we see no difference, and the only thing that we see is a slightly lower average pregnancy rate, which is something that is pretty known when you use vitrified oocyte. So this was published 2 or 3 years ago in Human Reproduction, and we need to remember that this is in young oocytes. And I'm saying this, so there are some comments on this study. So first of all, what we can say is that there is a relatively wide window to perform ICSI in this case without problems. Which also is the same thing as saying that if you have young women, there is no really ideal moment to perform ICSI. What do we can say about this study is a huge study with thousands and thousands and thousands of oocytes. And so this number of cases and the fact that the timing that is collected is absolutely automated and so is perfect to the second makes the study very robust, so you can trust the results. However, I will never stop saying that when you do a retrospective study, there are other variables that you cannot control of, and they maybe are not even collected in your database that may have an effect. So it's a robust study, but it doesn't compete with a prospective one. And also, like I mentioned at the beginning, we know nothing about very, very short times because we don't have them. So if it's less than 1.5 hours, I don't know what will happen. So when we published this paper in the last round of revision, one of the reviewers, I remember, made a comment and say, okay, this study is done well, is robust, so let's publish it. However, if you exclude women that are of advanced maternal age, if you exclude women that have some family history of infertility, if you exclude all these women that are actually our patient, then what is left? Who can use these results? And it's really true, because these are donors. So on average, they are 26 years old, and it depends on the country. But for instance, in Spain, where I'm based, the average age of patients that come to our clinic is 10 years older than 26. It's 37, 38, even longer, even older. And also donors are basically proven fertile. Many of them have children, or the recipients have had some children. So this is not your typical infertile population. And we took at heart this comment of the reviewer, and so we decided to basically do another study in which we did exactly the same thing, with the exception of the vitrification, because patients usually do not vitrify the oocyte apart from social freezing, but then we don't have a big number of people that came back. So we took away the vitrification warming part, and just by looking at fresh oocyte, we basically repeated the analysis. And in this case, the numbers are a little bit different. We had about 1,500 cycles. In terms of oocyte, this is about 20,000 oocyte, more or less. And again, we use the same system, so everything is automated, independent from the operator, and exact time recording. And these are the characteristics of the patient. You see that they are very different. The women now are 38-year-old, they're not 26. Also, as a corresponding characteristic of their cycle is different. They have on average 6 M2 oocyte, and this infertilization rate, this is ICSI again, and this is very different from what you see in donors. The male partner was 43, 44 on average, and about 40% use donor semen, and fresh semen in 35% of the cases. Now, what did we found? So if we look at the effect of time or reproductive outcome, and this is non-adjusted results, so without controlling for all the other variables, you see that apparently you again have no effect of time, because the p-values are all very high, on reproductive outcome. But this is unadjusted, so this is without taking into account all the other factors that are known to have an effect on reproductive outcomes. If we go and if we look at the adjusted analysis, so if we take into account the age of the woman, the BMI of the woman, if the semen is fresh or frozen, if the semen comes from a donor or from a partner, the day of embryo transfer, the number of embryos that have been transferred, and the quality of the embryos that have been transferred, if we control for all of this, then the story is pretty different. You see here that it becomes very significant, the effect of time on reproductive results in terms of both biochemical pregnancy, so basically implantation, and clinical pregnancy. In this case, clinical pregnancy is defined as the presence of a heartbeat at week 7-8 of pregnancy. So this is pregnancies that has been clarified and identified by ultrasound with a fetus and a heartbeat. So this is something that we should think about, because it's very much opposite to what we saw with younger oocyte. And in order to check a little bit further, we try to understand what kind of impact this has, right? One thing is to say that there is a significant impact, but then we try to quantify it from the clinical point of view. And we do this by using a different type of regression, the lowest regression, that is basically designed to estimate what is the effect over time. And by doing this estimation, we can say that for every 1 hour of time waiting in vitro for the oocyte of older women, we have a lower likelihood of pregnancies corresponding to about 8%. So with every hour that we wait, we lose about 8% of pregnancy rate. And this is quite a significant decrease. Now, when we go further in the pregnancy, things change actually, because if we look at ongoing pregnancy and live birth, you see that here the difference is already not significant. So it looks like the main effect of time is on early pregnancy and it doesn't reach live birth. So on the one end, you might say, okay, then we don't care, because if there is no effect on live birth, why should we care? We don't have less babies. On the other end, because of the way the study is designed, it is the more you go away from the point that you're looking at, the more confounding factor come in that you cannot assess, and also the smaller the sample size becomes, because the pregnancy gets lost progressively, so you have much less live birth, for instance, that you have betas. And so it might also be a matter of the study not having enough power to see the difference in this later stage of pregnancy, and not necessarily that the difference is not there. Again, this is an adjusted analysis, and you can appreciate here for what kind of variables. Again, all variables that are known to have an effect on pregnancy rate. So these are taken care of. They don't affect this p-value. So we have published this other study, again in human reproduction in 2018. And when this came out, it was a little bit of a discussion opener, because so far people were very much convinced, and there is still this sort of legends in the lab that you have to wait 2 hours, you have to wait 3 hours, you need to denude before, or no, you need to denude but leave the cumulus cells there. And there are all sorts of protocols, but very few of them are actually fundamented in evidence. And so after we published this, other groups also started to do these very large studies using an automated way of recording time. And one of them is this one that I present here from the group of Laura Rienzi in Rome, in Italy, and they did something very similar, and in fact they confirmed the same results that we found. Both these studies, like I show you, are retrospective, but then very recently, in fact last year and this year, 2 prospective studies have been published, and they basically found exactly the same thing. And so we can now say that there is a more robust body of evidence that tell us what to do with timings in the lab as far as the oocyte is concerned. So I would like to finish with a couple of slides on recap and some recommendation on what to actually do in your laboratory. So what it is pretty clear is that there is this interplay between the age of the woman, or if you want to express it differently, the health of the oocyte, and the oocyte ability to withstand in vitro aging, to the resilience of this oocyte in vitro aging. And so, like I mentioned at the beginning, older oocytes are more prone to activate it spontaneously. And by doing so, they dissociate the biochemical effect of sperm entry, so basically fertilization, to the release from the meiotic block. And you can see, and maybe this is the reason why some studies in the past have indicated that it's better to wait, because if you look at reproductive at laboratory result, you may see an apparent increase in fertilization rate, which does not result in better reproductive outcome. So, sorry, this lower resilience result in lower chance of biochemical and clinical pregnancy rate if we look at older oocyte. And of course, there are several factors that can have an effect. So some of them we could analyze, some of them we could not analyze, and this warrants perhaps a little bit more research. And we cannot exclude, I would like to repeat this, we cannot exclude an effect also on live birth rate. You saw that we did not find it in older women, However, like I explained, the design of the study and the fact that there are other confounding factors as the pregnancy progresses that we cannot control does not allow us to say absolutely with certainty that there is no effect on live birth rate. So I say that we cannot exclude an effect on live birth rate. So what should we do? So practically in the lab. So we can leave sort of at the end of the line the oocytes that come from younger, healthier women without any significant or clinical effect on reproductive outcomes. Of course, we shouldn't do this on purpose, but if there is a busy day in the lab, even if the ovum pickup was earlier for a young oocyte, there is no risk in leaving it a little bit longer, half an hour, 1 hour longer, and allow an older oocyte to be fertilized earlier. Limiting oocyte in vitro aging in general may improve reproductive results, or at least not damage reproductive results for patients that use their own oocyte. And we need to be careful when we use just laboratory KPI to understand the oocyte damage, because they may not capture the full extent of the damage, and in fact they can work against logic. So I would like to stop here. I will be very happy to answer any question that you may have, and thank you very much for being here.
Thank you, Rita. Brilliant as always. I have one question, actually. It is related with the warm oocytes. What do you think about older and younger women? Because they said that the spindle in the older woman needs more time to reassociate, and the ICSI procedure should be postponed in time. But in younger women, it's not a problem if you inject the egg after 1 hour after warming. What do you think about this?
Yeah. So, well, first of all, we need to be clear and say that the vast majority of data in the literature, they come from young women. So the solid knowledge is from young women, basically donors. And the case of older women, they're usually either older, so social freezing in women that are 38, 39, 40, or younger women, but that they have a systemic disease usually. So these are fertility preservation, usually for cancer or for other systemic issues. So they're not really 100% comparable. In young women, it seems to be established that a couple of hours of recovery after warming is enough. In older women, it's not so established, as you say, and it might well be that it will take a little bit longer. In general, in older women, the oocyte has a lower quality across the board. It's not just aneuploidy, it's much more than that. So if it's possible to wait a little bit more, I think it would be better. One point that I would like also to make is that we should not confuse, but I mean, this is a little bit obvious, but just as a reminder, we should not confuse the fact that in general that we see not for vitrification in general when we look in the lab. We should not confuse the presence of the polar body with the presence of the spindle. We know that they can be dissociated, and one does not necessarily automatically mean the other. This is mostly relevant for those oocytes that are, let's say, M1 when we collect them. Then we wait for a few hours, and then when they extrude the polar body, then we consider them available for fertilization. We should wait a little bit longer, actually. This has been shown that is not immediate. So one thing is not the other. And then one last comment about freezing and thawing, well, vitrification and warming of women, of oocyte of women of advanced maternal age. There are data, mostly from model system in mice, that has shown quite clearly that the effect of vitrification and warming, while relatively minor or minimal in younger oocyte, it becomes really substantial with older oocyte. It does not appear evident in the laboratory. You would have good fertilization rate and you will have decent development of blastocyst, but then the reproductive outcomes independently of the proportion of aneuploidy. The reproductive outcomes, because of the damage of vitrification and warming, are really significant in all the oocytes. And I'm saying this because sometimes we have this idea that, let's say, imagine the situation of having some oocyte vitrified at 39, and then the woman come back at 41 and says, what should I do? And in those cases, it is recommended to have a fresh cycle at 41 because the outcome is not so different from a vitrified cycle at 39. This is, I see the surprise.
Yeah.
Yeah. I can share a couple of studies later on if you want.
Thank you. It was very, very interesting. Yes, Dr. Volkova, please.
Thank you very much for a very interesting lecture. My question is about immature oocytes. When you compare different times for denudation, do you find a different percentage of immature oocytes? And what percentage you think it is normal to be from all oocytes to be immature?
Yeah. So the proportion, so we need to differentiate GVs from M1, no? The immature because they are in GV or immature because they are in M1. So the oocytes that are in GV, well, they are in GV, and there's more or less nothing can be done for them. They will, about a good majority of them will mature if you leave them, but their developmental potential is really low and they're usually not used. So let's focus on the one that are halfway through the process. No, they are in M1, and so usually that kind of oocyte should be there in about 5%. More or less 5% of oocytes are in this situation. If it's a lot more than that, especially if it is stably more than that, I think the protocol of stimulation should be looked at, because probably trigger is either too early or the ovum pickup is too early, one of the two. So in the time of denudation, the time of denudation does not seem to have a very significant effect on anything. And if we look at the biochemistry of it, so you know that the cumulus cells has many use and many functions, but one important one is to allow for a bidirectional movement of small molecules and nutrients from the oocyte to the cumulus cells and from the cumulus cells to the oocyte. This is done through gap junctions that are present on the surface of the oocyte. So these gap junctions, which are basically the means of communication with the cumulus cells, they close progressively as the oocyte matures, and they are completely closed before ovulation. So the fact that we keep the dying cumulus cells around the oocyte for more or less time does not really affect what happens inside of the oocyte, not after ovulation. So it has no effect, basically. It doesn't matter.
Thank you very much.
There is a very funny comment from one very close to me Belgian friend that he said if the oocytes are not in metaphase 2 during the punction, the egg retrieval, and you cannot vitrify them right away, you should vitrify your gynecologist.
Well, okay. I'm not a gynecologist, so I can subscribe.
Yes. Just a funny comment. Thank you, Rita. It was very, very nice to have you here with us, and we hope to invite you personally when this crisis with COVID ends, and to have you back in Sofia next year.
I would love to. Thank you so much.
Thank you, Rita.
Enjoy the rest of the conference. Bye-bye.